Good evening, everyone. Thank you so much for joining us. We are really excited to start yet another session of Child Mental Health Community of Practice, and today's session is about anxiety. Before we start our session, we would like to formally acknowledge the country. Northwestern Melbourne Primary Health Network would like to acknowledge the traditional custodians of the land on which our work takes place, the Wurundjeri Woi-wurrung people, the Boon-wurrung people, and Wallarong people. We pay respects to elders past, present, and emerging, as well as pay respects to any Aboriginal and Torres Strait Islander people in the session with us today. To formally kickstart our session, let's have a look at some housekeeping rules. So at COP, we agree to stay on mute unless speaking. Raise your hand to speak. Keep conversations confidential. If possible, please keep your camera on. Introduce yourself and your role when speaking. Share ideas and promote everyone's participation. Acknowledge that we have varied learning needs and interests. Ask questions. No question is silly. During the education component, please ask the questions via the chat box. This session is being recorded, so please ensure you join the session using the name you registered with so that we can mark your attendance. Certificates and CPD will not be issued if we cannot confirm your attendance. Just some tech thing, how to change your name in Zoom meeting. Click on participants. If you're joining through an app, click on your name. If from a desktop, you can hover over your name and click the three dots. If joining from Mac, please click on your name and click More and click on Rename. Please change your name to the name that you registered with so that we can issue the CPD points and the certificates. Our presenter and psychiatrist for this series is Dr. Prakash. He's a senior consultant child and adolescent psychiatrist at RCH with over 20 years experience. He has worked in and managed general and specialist clinics with child psychiatry in metropolitan and regional public mental health services. He has worked with children and adolescents from 4 to 18 years of age, assessing and managing a variety of mental health issues. A bit about myself, I'm Saha. I'm a GP who works in Sunbury, both in normal GP clinic and now recently in urgent care as well. And my areas of interest are child and adolescent mental health and chronic disease management. So I'm going to hand over to Dr. Prakash, who would present the education component. Thank you, Dr. Prakash.
Thank you, Dr. Saha. Lydia, are you able to operate the slides, or do you want me to do that?
I can do it for you. It's up to you.
Oh, okay, thank you. If you could do that, that'll be might be just easier. Then you could finish
fine.
off and go into the. Thank you so much. Thank you. I will try to cover a sort of short summary glimpse of the current understanding of anxiety disorders and OCD and their management, both medication and psychological therapy. Just starting with some definitions, an emotion is a brain state that is associated with the perception of either a reward or punishment. So it's a happy or a negative sort of thing, a happy emotion or a negative emotion. Fear is a family of brain states or emotions resulting from a perception of actual danger. And anxiety is brain states associated with fear that is inappropriate to the context, either in focus or extent or both. And pathological anxiety is an exaggerated fear state in which the hyperexcitability of the fear circuits that includes the amygdala and extended amygdala, which is expressed as hypervigilance and increased behavioral responsivity to fear stimuli. So that's basically pathological anxiety is increasingly being seen as a biological reaction. In terms of the hypotheses, there are obviously the behavioral and the neurobiological. Basically, anxiety is known to be centered in the amygdala nuclei, the basolateral and central nuclei, and the cortical and prefrontal cortical projections from there back and forth. And that's kind of how. So there's this attention, which is in the prefrontal cortex, is emotion emotion-laden attention, which is in the inferior part of the prefrontal cortex. And all of that then links back to the amygdala, which is the relay center for anxiety. And the hyperexcitability of the amygdala is the one that keeps the anxiety going. So a person develops anxiety disorder when they have a hyperexcitable amygdala. In terms of the behavioral sort of explanation, is that they feel that anxiety can result out of cue-specific and context-specific stimuli. And there are some stimuli that are triggered by certain stimuli. I mean, some anxiety that is triggered by stimuli, and others that are specific to certain situations, and during interactions with certain people, or the anxiety might be only in certain relationships, like home or school and things like that. The understanding is that fear conditioning happens either which is cue specific or context specific, and that then develops into an anxiety disorder. Anxiety is often related to worry, but there are some differences, and I'll try to explain some of that. Worry is more verbal or linguistic in nature. It's not so much feeling related. There is a narrative of what causes the worry that runs through the brain constantly. It's future focused. It relates to real life triggers. So in a way, it is more realistic, although there can be people who may worry excessively. Worry at the start relates to something that is realistic, and then that persists. Often worry with its verbal linguistic narrative that runs through the brain is quite helpful for problem solving and the process of coping, because it allows the person to think about, what am I worried about? Why am I getting worried about this? And so on and so forth. And then through that process, the person is able to actually go and take that to someone and discuss it with that person, be it a family member, a friend, or a colleague, or a partner, or somebody, or a counselor, and then they are able to find solutions. In terms of the prevalence of anxiety disorders, not including OCD, anxiety disorders of all of the other kinds combined is 3 to 5% in children, with a lifetime prevalence of 4 to 9%. The risk of developing an anxiety disorder is significantly higher if a parent has an anxiety disorder, or if a parent has a substance use disorder, compared with parents who do not have anxiety problems or substance use problems. So if a parent has an anxiety disorder or a substance use disorder, or both, the risk of anxiety in the children is significantly increased. The twin studies indicate that there is a 30 to 40% heritability with multiple genes involved. There are also lots of non-genetic factors like parenting style, social learning, childhood adversity, exposure to maltreatment, just living in lower socioeconomic status, and neuroticism as a temperamental trait, which predisposes people to have an anxiety disorder. In children and young people with intersectionality, they found that there is a significantly higher level of incidence in children with intersectionality, that is young people with ASD, children and adolescents with ASD mainly, with the most common types of anxiety disorders being social phobia, specific phobia, and generalized anxiety. Similarly, in the LGBTQIA+ population of youth between the ages of 13 and 24 years, 73%, this is the Trevor Project Raw kind of poll, found that 73% young people reported significant symptoms of anxiety, and 58% reported significant symptoms of depression. Now, what we don't know is how many of them have persistent problems over many years, or whether this is during the period of adjustment and coming out and having the world accept them and all of that sort of stuff. That's the period when they're more likely to have mood and anxiety problems. Anxiety is one of the conditions with the most comorbidity amongst the various mental health problems in the children and adolescent population. Depression is a very common comorbid condition, with rates ranging from 17% to up to 50%. And anxiety symptoms in depression are also quite significantly associated. People with anxiety disorders can have OCD. Young children with anxiety disorders can also meet criteria for OCD. There is a kind of a repetitive quality to the worrying and the anxious thinking that is seen in young children, which ticks the box for a diagnosis of OCD. They may or may not fulfill all of the criteria, but they do have a significant history of OCD. Post-traumatic stress disorder is another thing. They also found that when children have a diagnosable anxiety disorder at 7 years, they develop depression and dysthymia when they get to 10 years and 13 years. The major depression by 14 years and dysthymic disorder by 11 years. So anxiety disorder predisposes young children to developing depression in the adolescent years. Similarly, 23% anxious children had ADHD, according to a study, and 32% had conduct disorder and oppositional defiant disorder. So aggression and antisocial behavior is quite significantly associated with anxiety disorders in younger children and in adolescents. In terms of the evidence-based treatments, mostly in the pediatric population, the support is for cognitive behavior therapy and other forms of therapies, such as sort of mindfulness-based CBT, and now increasingly ACT, which is acceptance and commitment therapy. It's actually called ACT now, and also mentalization-based therapy. But CBT has been the one that has been, DBD is disruptive behavior disorders, and DD is dysthymic disorder, and MDD is major depressive disorder. Amongst the various types of interventions, especially in the pediatric population, simple basic CBT strategies, including psychoeducation with the parents, modeling, exposure and response prevention, systematic desensitization, relaxation training, assertiveness training. These things are quite helpful and useful. They appear pretty simple and basic, but they are quite effective in young children with anxiety disorders. CBT obviously requires verbal linguistic skills, motivation, and application, so it may not work with everyone. In younger children, parent work with dyadic parent-child work may be combined with the child-focused therapies. So working with the parents is quite important. Also, I think inadvertently parents reinforce some of the anxiety avoidance behaviors. So I think it's quite important to kind of involve them in the treatment work as well. If there is generally, what we suggest is if there's a lack of response to CBT, that's done very well with the young person engaging in the treatment. So I think it's quite important to first find out whether it's CBT that they are receiving, because often doctors, pediatricians, and GPs might sort of say the person is seeing a psychologist, they've been seeing them for a long time, and that's what we go. And I kind of ask people, I pull people back and I say, have you checked? Do you talk to them and find out what exactly happens in the sessions? Are they able to tell you? Because young people who are actually engaged in CBT and who are fully engaged in the CBT and who are practicing the strategies ought to be able to tell you what they're doing. They have to be able to describe that. They're not able to describe that particularly well. Perhaps they're not completely engaged in it, or they haven't sort of understood what they have to do. They're simply kind of going through the motions of the therapy process. So I think it's kind of really important to find out if they are, what sort of therapy they're engaged in, what kind of skills training they're engaged in, and then kind of decide what's the next step if that's not working. There are some instances where, for example, there are some differences between like basic CBT and modified CBT for young people who are neurodiverse, mentalization-based cognitive behavior therapy, mindfulness-based cognitive behavior therapy, and interpersonal sort of CBT and things. Slight differences in terms of focus. The focus in some of those things can be more specific to interpersonal relationships or learning mindfulness skills more than the behavioral component and things like that. And that people tend to tailor the treatment. And I'm sure the psychologists in the group will be able to speak to that. when we have the discussion, that it's often tailored to the young person, it's tailored to the child, it's tailored to the parents who come, and the kind of work you do is very much tailored to what they can cope with. And we often use play therapy in the very young children to impart the CBT, and that changes how we do CBT as opposed to doing the CBT with an adolescent. So if the symptoms are extremely significant with school avoidance, significant sleep disturbances in the nighttime, it's really hard to even get the child to come and see you in the clinic and that kind of stuff, then you may have to go in with medications earlier. Whereas if they are engaged in the treatment and treatment seems to be working, then you might have a wait and watch kind of approach. Obviously, all SSRIs have the black box warnings. We don't believe that one SSRI is any more safe than the other. I think there was this belief that fluoxetine was safer, but not necessarily the case. Fluoxetine, there's more evidence for fluoxetine, but we have also seen young people with who have been put on fluoxetine who have significant activation symptoms, and that results in hypomanic symptoms, self-harming, significant self-harm thoughts, and things like that. So it's how the person copes with it, which is a very individualized thing. So I would always say start really low and go up really slowly. So for generalized anxiety, social anxiety, start with fluoxetine, even 5 milligrams, sertraline 12.5 milligrams. For depression mixed with the anxiety, you might start with fluoxetine 10 milligrams and sertraline 25 milligrams and things like that. But if you're treating OCD, you have to be prepared to go up really high. So that's fluoxetine 80 or 100 milligrams, and sertraline, we have used sertraline up to 300 milligrams in some adolescents, but it's a stepwise process. You take your time. Each dose you wait for 6 to 8 weeks, and you look at the effectiveness of it, and you gather information objectively from a range of people, from the parents and school, there are some rating scales that you can use, that you can get them to complete and bring in. So again, fluoxetine may activate a very activated heightened child or teenager, and that's because fluoxetine binds very strongly to the serotonin receptors, and because of that, there is a much larger release of the serotonin initially in the first 4 to 6 weeks. So there's a slightly higher risk of activation in fluoxetine compared to the others, but not very much more. But it's just something that I wanted to stress, because there is still this belief that fluoxetine is the safest and you always go to fluoxetine. May not be the case. It's now increasingly thought about as something that you have to kind of manage on a case-by-case basis. So I tend to use sertraline, which does not bind very strongly to the serotonin receptors in a very, very activated child. I would go to fluoxetine in a child who has more depressive symptoms, who's not motivated to engage in treatment, who's not motivated to push themselves, that sort of stuff. They need a pickup, and I think fluoxetine can be quite useful. There has been some case reports of citalopram and escitalopram causing QT prolongation and things like that. I haven't come across a single patient who has had significant tachycardia and arrhythmias due to the use of citalopram and escitalopram, but it's something that we need to be mindful of. We tend not to use paroxetine in teenagers, but I'm seeing that I've seen a few young people who are on. Yes, it is okay to use escitalopram instead of citalopram. Yes, certainly. Citalopram can be sedating. So sometimes in some young people, it can be a nighttime prescription to help with sleep. Just like with fluvoxamine sometimes can be helpful for sleep in the nighttime. We tend not to use paroxetine because there's definitely a higher risk of suicidal thinking. But I have seen a few teenagers who've come to see me who've been prescribed paroxetine by other doctors. So duloxetine is the only SNRA that has got FDA approval for generalized anxiety disorder in children and adolescents, but it does have an impact on liver function, so it's good to monitor that. There's not that much sort of information on pharmacokinetics, pharmacodynamics in young people and children. Much of it is adult data that's sort of extrapolated to young children. There is the venlafaxine extended release. There's desvenlafaxine. They have long half-lives. So, and duloxetine as well is like that. So you can manage with once a day dose. But the venlafaxine immediate release requires twice or thrice daily dosing, just like the fluvoxamine. Buspirone is another one. Escitalopram does not have a very significant weight gain side effect. Mirtazapine does, and we use mirtazapine in some instances, especially if it's combined with depressive symptoms and sleep problems. Sometimes we use mirtazapine, and that is associated with weight gain. With buspirone, at least 2 randomized controlled trials that have shown small effect sizes in generalized anxiety disorder in adolescents. And the dose will be a mean dose of 25 milligrams a day, or a kind of an average between 10 to 40 milligrams a day. I took the opportunity to kind of have the slide up there. There is this entity of pediatric medical trauma stress. You probably will see a number of children and young people who have chronic illnesses, who have had to have admissions to a hospital, and who have had to have treatment in a hospital with kind of procedures and surgeries and things like that. So it's can be quite a significant stressor. And basically, the entity of pediatric medical trauma stress is something that is recognized now and described. And although it has not made its way into the DSM-5, it is an entity that kind of is becoming increasingly recognized, at least with most of us in the practice within hospitals. So they say that often what happens is that there are pre-existing factors in the individual that predispose them, which might be a biological predisposition to anxiety, to OCD, to depression, so other mental health problems. And then they may be exposed to a traumatic event. The traumatic event could be a motor vehicle accident, or a diagnosis of cancer, or a diagnosis of some other illness that has resulted in them needing to come into hospital to have surgery. It's unexpected, it's very sudden, and the experience of the person, the subjective experience of the person, is quite scary, and they were, extremely traumatized by that, either being in long periods of time waiting in the emergency department surrounded by very unwell children and teenagers, or being brought into the ward and being subject to painful procedures repeatedly, and so on and so forth. That's in the peri-trauma stage. And then there is the early ongoing evolving trauma. There are the early acute responses, which are very similar to an acute trauma state, and or an acute stress disorder where there is shock, and then there is kind of confusion, and the person is cognitively overloaded, and that may be followed by more PTSD kind of thing. But what they say is that in a very large number of young people and children and their parents as well, and that's the other thing here, that in pediatric medical trauma stress often also affects the parents of the children that go through these treatments in hospital, that they have sub-threshold levels of pediatric medical trauma stress. I think there's a question in the chat. What is class as buspirone? Is a 5-HT1A agonist. So it's not a reuptake inhibitor. It's an agonist. It's a serotonin receptor agonist. In terms of OCD, the 3 months prevalence is about 0.2, point prevalence of 0.06. It's relatively rarer compared to the rest of the anxiety disorders. That lifetime prevalence is 2 to 4%. It occurs more commonly in males than females. Most of the data, you will find that they have not started to yet include the third gender or multiple genders. We just continue to refer as male and female, which is problematic in many ways. It's a 7% incidence in the clinic population, most often associated with social anxiety and specific phobia, generalized anxiety, and agoraphobia. About 23 to 70% of very young children have a chronic course, but a significant proportion of young children with OCD remit. But it's not unusual to have young people who need CBT-based therapy and or SSRIs when they have significant symptoms at the start, for them to have treatment over 1 or 2 years, before which slowly we can taper down the medication. Maintenance treatment is needed after 3 to 4 mild relapses or 2 to 3 severe relapses. So maintenance treatment would be running for 4 to 5 years of some dose of CBT with some dose of SSRI with monthly CBTs. With regards to the CBT, with regards to the SSRI dose, it's gradually tapered over 1 to 2 years by reducing by 25% every 2 months, whilst the CBT is going on, the maintenance CBT or the monthly CBT is going on as well. But 25% of children with OCD also seem to have comorbid ADHD. Whether that's because the anxiety and the OCD cause the restlessness and impulsiveness, who knows? We don't know, but they meet criteria for DSM-5 ADHD as well. ASD is very often associated with OCD, and ASD is more readily diagnosed when you have the higher functioning ASD. Like, for example, in the old language of DSM-4, we had atypical autism, Asperger's syndrome, PDD, NOS, and all of that. They are more associated with ASD. They are more associated with OCD than the sort of classical childhood autism. The youngest age in which I have prescribed SSRIs is 5 years. I've not prescribed SSRIs prior to that age. I have prescribed things like liquid clonidine and things like that, which I'm happy to talk about further. In the prepubescent children, we tend to use CBT first and try to maintain them on CBT for as long as possible. But if the symptoms are severe, then we might add in the SSRI earlier. And there are some types of symptoms that are more likely to respond to certain types of CBT. So pathological doubt and moral guilt and scrupulosity and all these things are more cognitive-based therapy, whereas some of the other ones, like the contamination, symmetry, hoarding, counting, they are more they respond better to exposure and response prevention. If using SSRIs, we have to be prepared to push it to the maximum, and maximum meaning a sertraline dose of 200 or 250, fluoxetine dose of 80 to 100, and so on and so forth. And trying each dose for 4 to 6 weeks or 6 to 8 weeks even. And after reaching a high dose that is tolerated and the person is still not responding, then probably switch to another SSRI. After trials of 2 to 3 SSRIs plus CBT continuing at the same time, then try clomipramine. Some people bring in the clomipramine sooner, and some people then do augmentation. So, for example, if the person's symptoms appear to be associated with body dysmorphic disorder, they appear to be associated with more rigid, fixed thinking, then people might consider bringing in antipsychotics like risperidone or quetiapine and things like that. So again, CBT is the first line of treatment, and family-focused CBT. There are lots of sort of other therapies where studies have been done for CBT with sertraline and CBT with family, the individual CBT with the family interactional therapy and various other things. But CBT is certainly, for the pediatric age group, is the treatment, the first line of treatment. Whether or not we do anything else, the person needs to be engaged in CBT. So in summary, anxiety is due to genetic, cognitive, behavioral causes maintained by neurophysiological mechanisms. It's a higher incidence in children who are neurodiverse, have a history of psychological trauma, and suffer social discrimination, such as the LGBTQI